I'm going to get us started. How you doing, Jennifer? Oh, Jennifer, I'm going to give you...
Doug, how are you doing?
How are you?
Pretty good, pretty good.
I'm going to make you co-host. Is that okay? There we go.
Sorry, Doug, I had some problems, but now it's okay.
All right. Very good. I think we're good now. How's everybody doing today?
Morning.
Good
Jadit's
morning.
over here.
You.
Morning.
Good morning, everybody. So we're getting ready to start. Let me see if Dr. Call is here and Camilo's here. So one of the things we want to announce today is that we finally put together, thanks to Camilo's hard work, the evaluation app, which is basically going to be Hispanovida and COVID risk eval. So basically, what we have done is that as you know, the main issue with contact tracing has been that the amount of time it takes to get the results for a COVID test. So for a PCR test is normally taking 3 days, 7 days, sometimes 10 days. And what we've noticed is that, when the most infectious period is probably the 2 days before symptoms and the first 2 days of symptoms. So by the time somebody gets the result back, it's probably a little late for contact tracing because basically that virus has probably moved on already. So the purpose of this app is to basically have people put in symptomatology, and based on that symptomatology, there's an algorithm that was used in Guayaquil, Ecuador, that was very successful in predicting whether somebody had a high risk of COVID. And then once that person was identified, then what they're doing over there is that they're connecting them to care. What we're going to do here is that we're going to connect them to a contact tracer. And then you guys will do the contact tracing as a presumptive positive until the test results come back, or maybe the person needs to be scheduled for a PCR test. And then we're going to correlate the PCR test results with the symptomatology on the app to see if there's a big correlation, and see which maybe we need to tweak that formula a little bit. But as a base, we used whatever they used in Ecuador as a starting point, and then we can always improve on it. So with that said, Camilo, you want to show in your screen, you want to share your screen and just take us through how the app works?
Hello, everybody. So I'm going to open a new browser. We just connected this, so there still might be some issues with the certificates saying it's a trusted site. If you can go to covidriskeval.com, it should redirect you. I'm getting a secure connection already, a certificate from Google. Hopefully the certificates are generated all today, so we don't have any issues with people having to click advance. So with that said, it's a new site. Just be aware there might be some certificate issues. Once you land on the page, you have two options: sign in, sign up.
So just to clarify, so sign up is a new person that signs up and they put their information. Sign in is somebody that's taking the test before, that's taking the questionnaire before, and maybe they were low risk at the time, but now they have new symptoms and they want to take it again. So they're able to take it an unlimited number of times, and so that it can recalculate their risk. Go ahead, Camilo.
Yes. So we're gonna go through a completely brand new sign-up process.
So basically, he's inputting his email address, and then he's creating a password. So it's pretty straightforward.
The first time you log in, it's gonna ask you if you want to allow your location to be shared. Here, it's gonna make you accept the terms and conditions before proceeding.
So as you can see, the terms and conditions were basically illegal things. It's things like, you know, you could be positive for COVID and have no symptoms. So obviously we don't want to say that just because you have no symptoms means that you cannot transmit COVID. It just, you know, we're using symptoms as a way to make you presumptive positive. We're not really guaranteeing that you are negative for COVID. So, you know, those are just legal things that we have to, you know, unfortunately, we live in a litigious environment. So we want to make sure that we don't end up with a lawsuit because somebody says that they didn't have any risk of having COVID.
After you scroll all the way to the bottom, it will show you the I agree button. You can click and agree your terms and condition. It will take a stamp, a timestamp of that. Before it allows you to proceed as well, it's going to ask you to complete your user profile. Just give us some basic information about you.
So he's signing up, he's putting in his all his information. So all of this is as he keeps going, you'll see what we're trying to do here. So one of the things we're trying to do is we're trying to figure out where the hotspots are. So when they put in their address, we're going to have geolocation ability so that we're going to be able to do maps. So we'll be able to do a map of where all the people with symptoms that are high risk for COVID are. Obviously, we're not going to identify them by name, but we'll have a map of, say, a particular area. We'll say, wow, there's a lot of people in this particular area that are using the app and are coming up high risk. So maybe there's something going on in that area. Maybe there was a recent party. Maybe there was some super spreader event.
Finally, after you put in your basic demographics, it's going to ask you if you've been tested for COVID-19.
So it's important to know if you've been tested or not, right? So if you've been, because some people may have been tested and they're just waiting for the results. We want to know if they've been tested or not. If they haven't been tested, when they're assigned to you as a contact tracing specialist, your job is to get them tested, because basically you want to confirm whether they're positive or not. Even though you're going to do the contact tracing as you normally do, you're going to assume that they're positive. But still, I would. So in this case, when you call the contacts, you're going to say there's a presumptive positive, not an established positive. Let's keep going.
So if you hit tested, additional things will pop up. Just the date of your test, the name of your testing location, and what was your result. Okay. Once you fill everything out, this button would appear, and it will allow you to continue.
So the beauty of it is now everything that person just entered is now in the COVID Fighter app. So now they just open an account in COVID Fighter, so that then you can use that eventually to start the contact tracing. So now these are the symptoms. Each of these symptoms has a weight scale. So for example, if you put nausea, it might have a weight of 1 or 2 or whatever that number is based on whatever their experience was in Ecuador. And so that's what it correlates to. So at the end, it adds up all the points, and if it goes above a certain point scale, it correlates with risk for COVID. So let's try someone who's at low risk for COVID. Camilo.
Okay. So I'm gonna say that all I have is a headache, and I don't have any medical conditions at this moment.
I haven't been in contact with anybody that's positive. So it says now you're low risk. It says here, based on your symptoms, you're low risk. Then you can still be positive because you may be asymptomatic. And then these are the guidelines to protect yourself. And this is a link to the CDC website that talks about how do you protect yourself, from COVID. So that person doesn't need to do anything else. So now let's go back and now figure a medium or high risk person. So medium or high risk, we're treating them the same. We're treating them as a presumptive positive. So now somebody that has a bit more symptoms. Now this person has a absence of loss of taste or sense of taste, Camilo, loss of smell. Those are very high correlations with COVID. Sore throat, okay. I think those two alone would do it. And then now contact with somebody positive. So those three are going to lead to a medium or high risk.
I think this one would be medium risk here. Oh no, it's still high risk. Okay.
Yeah, because of the weight of the symptoms. So this basically says now you're going to be contacted with a contact tracing specialist who's going to contact you. So one of the things you're going to do is arrange for a test. Why do we want to arrange for a test? Not because this person needs it in particular, but because we want to see if our app is predictive. We want to see how many of those people end up really being positive for PCR testing so that we can say, wow, this is a very accurate app. It's almost as good as a test. But we can't do that if we don't correlate with a result. That's why we want to test them.
Okay.
And the test obviously is it's gonna go through either the CARES Act or their insurance. They won't have to pay for the test. This is a medium risk. Okay.
I'm gonna now pull up the administrative side of COVID Fighter app.
So now, as a contact tracer, this is what you're going to see on the administrative side of the COVID Fighter. Now, when somebody that's high risk just registered. So this is it's going to give you a warning to call them.
So it's loading the profile. This is the information that is basically pulled up from here. You will be able to complete the questionnaire additionally, but we will be able to assign this new account to a CTS.
CTS.
Oh no, I just assigned it. Sorry. Somebody got an email. Okay. I am so sorry, guys.
Okay. So basically, we have administrators that assign contact tracers or CTSs to PUIs or persons under investigation. So this is what they would be doing once somebody signs up that's medium or high risk. So that's what we're doing. There's a Spanish website. It's called hispanovida.com. The English version is covidriskeval.com. So in Hispanovida is just translated. We're going to try a Creole version next. We're going to come up with a website that's Creole, that will be easy to write in Creole. The Spanish one is very easy, hispanovida.com. So very easy to remember. It's like Hispanic life. And the idea is that this could also be useful in areas where access to PCR testing is just not available. So this is the good thing about this type of an ad. So that would be good.
Okay. Do you want to go through the Spanish version or?
No, I think it's fine. I mean, let's. I
wanted to show you guys the reports.
Yeah, go ahead and show them the reports. Yeah.
So just finally, that all those reports that they are sending, they are integrating with COVID Fighter app, and their reports are going to be visible here. So we're going to be able to track how many days symptoms and so forth. And
it also, since if you go back and take the app again, what this will do is that it will have the history, like how many times you've used it, and it's been low risk, and then maybe you become medium risk or high risk. So it'll have a little bit of a history for that if you use the same username. Camilo, I see some. I'm gonna welcome people to either on Facebook or here to post on the chat any issues. I see that Jennifer is suggesting that instead of sign in, it should say log in and then sign up. That's a good point. So instead of sign in, log in, and that way it's log in and sign up. Does that sound right to you?
Yes. However the preference of your details are, I'll make it happen. No problem.
Okay.
So I'll write that down, and we can change that if you want.
Let's show them the Spanish. The Spanish, so that we can see what it looks like. So in Spanish it's ingresar, and this is registrarse. So I think that's pretty clear, right? That might work out fine.
Yep. Actually, if we don't have like a limit in the long of the word, somebody else, Jazzing, I don't know if I'm pronouncing good your name, sorry, but she or he said the login and register. I think that might be better because register is that you're registering to the site, and then login is just entering.
Yeah, Edmundo is asking him, but we should say register first time. I think the problem is we can't fit that many words, so we want to make it like one word. But I think these are good suggestions. So the idea is we want to make this viral, right? We want to make sure people start using it. It's free. There's no cost to it. If they use it and they want to get a PCR test, they won't have to wait in line. It'll be a very smooth process. They won't have to pay copay or any type of payment for the test, because basically they're helping us put this together and hopefully help other communities. I mean, there are going to be places in the world where you don't have access to PCR testing, and this could be an excellent alternative. I like several things about it. One, obviously, is the ability to geo find where the positives are. And so this is good because if you can identify hot zones, then it could go a long way. Let me just keep going through questions. It's saying this is only for Florida residents. No, this is actually for anybody in the world that wants to use this. Anybody that speaks English or Spanish. So that's the idea. Obviously, for the section about whether you get the PCR test for free, that's only be available in South Florida. But everything else is which should be accessible anywhere in the world. And any of you should be able to do contact tracing for that person. Wherever they are, as long as the language is the same, whether it's English or Spanish, and soon to be Creole, as we have the Creole course about to load up soon for contact tracing. Can it be used in Bangladesh? Absolutely it can. I think the main thing is if we're going to use it in an area, we need to just make sure that the CTS are aware that they're going to be getting calls from Bangladesh, because the issue is going to be what support services do we have in Bangladesh? For example, if somebody's short of breath, what do we tell them? Is it 911 that they call, or is it 123? The different countries have different codes. If they need COVID testing, where would they go for the COVID testing? Or do we tell them that there's just no COVID testing available in a particular province or in a particular city? I mean, there are, like, obviously the capital cities usually have access to everything, but sometimes there are places that are remote that may not. So we kind of need to know a little bit more about the country and know a little bit more about what's available. But definitely, I think if, Elora, if you want to put that together for Bangladesh, that would be great. This should be a worldwide application. Where do we direct them for testing if high risk? Okay, so if they're high risk, we're going to be offering them the testing at the hospital. So we're going to have, you're going to be scheduling them at the hospital. You're going to ask them to come to Palm Springs outpatient air department. So they're going to park, they're going to go to the area that says outpatient. This is Larkin Community Hospital, Palm Springs campus. And they're going to say that they were referred by the COVID risk or by the Hispanovida app. And then they will know already what to do. They will get their information. If they have insurance, they'll collect that. If they don't have insurance, it's no problem. All we need is an ID, and then we'll process it, and they will not have to pay anything for the test. Let's see. Previous in the section previous medical condition, shouldn't be there an option of known. Yeah, that's actually a good point. So Andres is saying, Camilo, that maybe we should have an option for none. Yeah, that could be, but I guess that none would have a weight of 0, right, Camilo? You could put that in your.
Well, I mean, you could hit next without hitting none.
Okay.
Like you can hit next without having any symptoms. If we add a button, we can add a button that says none, and it would have a weight of 0. Yeah, exactly.
Okay, so I don't know. Is it difficult to put none and I put a weight to 0 or no?
No, I mean it'll be basically a button that's just like a false button.
You actually, you know what? Call that a none. Make none next. You see what I'm saying? So do 2 next buttons.
If there is nothing selected, it will say none, like next. And then if there is something selected, it will change to a different button.
Okay, perfect.
We can do that.
Okay. Laura, yes.
Maybe,
yeah, go ahead. I'm sorry. Go ahead.
or maybe if somebody press on the option none, it could annulate the other options immediately and then proceed to next.
Yeah, well, it would be like a next. It would be the same as a next. See what I'm saying, Camilo? So make it have the same functionality as the next button, so it doesn't have any weight. It just moves them to the next.
So as soon as they click it, it just goes to the next page.
Just goes to next. That's all. So that way you don't have to worry about changing the algorithm. The algorithm is actually fairly complex because each of these conditions and each of these medical histories has a different weight and has a specific weight. Some of them have a weight of 2. Some of them have a weight of 1. Some of them have a weight of 1.5. Some of them have 0.5. I'm trying to get from the researchers in Ecuador how they came up with these numbers, and they're telling me that this is based on things that correlated with those diagnoses. So I haven't still been able to get a specific reason for it, but we have a meeting scheduled soon. One of the things that came up recently with the University of Southern California was that they're saying the order of symptoms can be sine qua non or could be indicative of COVID. For example, if they start with abdominal pain and nausea, followed by diarrhea, that is COVID. There's no question about that. So if the first symptom is fever or abdominal pain and nausea, and then it's followed by diarrhea, that sequence of events is pretty much high risk of COVID. So we need to incorporate that into this algorithm eventually. I don't want to overwhelm Camilo right now. I kind of want to have something that works. I think really right now, if they put diarrhea, it's going to be high risk regardless. So because I think it has a weight like 2 or something. So even if they have diarrhea with anything else, it's going to be high risk. But Laura is asking if she can translate it to Bangla. Yeah, I think you can. But the idea is, Camilo can just do a sub-page in the COVID risk eval for Bangladesh. So that would be fine. Yes, Laura. So you were recruited to translate it to Bangla. Excellent. Martin is saying, if we put Hispanovida, evaluación y riesgo de COVID. Yeah, at y riesgo de COVID.
Okay.
Instead of de riesgo de COVID, Camilo, y riesgo de COVID, you see?
Evaluación y.
Yeah, that's
just the Y.
The Y instead of the DE.
Okay.
So I like that.
Both words are like the same, but it's okay. With the Y, it's okay.
Yeah, Edmundo, regarding the cost, it's technically the test. If you have insurance, or even if you don't have insurance, you can get it for free at government drive-throughs. So, yeah, I mean, I'm not too concerned about that. Sasha is saying headache should be high risk too, as it can indicate neurological manifestation of COVID-19. You know what? It does have a weight, but headache is a very common symptom, unfortunately or unfortunately. So it is so common that you know it doesn't have really high correlation with COVID. So just a headache by itself. I mean, how many of you have had a headache in the last 4 months, and you may not have necessarily have COVID. So that's why it can't be, but in and of itself, just a headache cannot be high risk, make you high risk. I think it has a weight of like 1.5. Oh yes, if you add headache and angustia and anosmia, that the three of them add to more than 3. I think it's like angustia is 1.5, anosmia is 1.5, and headache is 1.5. So yes, if you add all of them, that's absolutely. Oh, I'm sorry, Laura. Her name is Tanvira. Okay, got it. Anybody have any comments or questions? You can type them on either on the Facebook live that we're doing right now, or you can also ask in the chat group. I think this takes us kind of a new level with this. Hopefully, it's going to work out really great. I'm sure it's going to take some adjustment. I mean, obviously, these things are not perfect, but the idea is that I think we got 2 pretty neat websites. Hispanovida is great, and COVID Risk Eval I think is great too. It kind of drives the point. Okay, Maliha, you have a comment? If you
Yes.
want, Camilo, stop sharing now, so that we can see everybody. Okay, go ahead.
Hi, everyone. Yeah, so I was reading an article yesterday. One of the emergency doctors in the US posted that she had symptoms of COVID-19, but she tested negative 5 times using the PCR tests and all the antigen tests, and everything that she tested negative, but she had symptoms. All her family members tested positive, so really she was really suspicious of it. A month later, when everyone got tested for antibodies, she tested positive for antibodies. So my point was that sometimes, and I read this article from John Hopkins study that 67% of the antigen tests would test negative in the first 4 days of contracting the virus. So we should really not rely so much on the test, but the symptoms should carry a lot of weight, I think. And if the POIs do have symptoms, we should continue to monitor them and then, take care of them like somebody who has a positive test. That's just what I was thinking.
Yeah, no, 100%, 100%. I mean, the ranges between 20 and 50% could be, you could have a false negative PCR test. So it's very, it's not unlikely to have a negative test and be positive. So absolutely. And this is kind of this is the only app that does this right now. The only other place where it's being used is in Ecuador. They were kind enough to give us the algorithm. We're going to perfect the algorithm, obviously, because they tested on about 25 to 30,000 people, but they have not really correlated it with the COVID positive test. So they haven't really done the work of saying, okay, we know for sure these people were positive because we did a PCR test. That's what we're doing, and we're going to make this part of a study. So we're going to basically say, okay, we use this algorithm that we got from Ecuador, and out of 1,000 people, 999 were positive for COVID that had these symptoms. And this particular symptom was basically sine qua non, which means basically gave you the diagnosis of COVID, whatever that symptom is. And I think it's going to end up being something like lack of taste or smell. Those are really high up there in the list. Even with a negative PCR test, I've seen a lot of people that end up being positive ultimately, or end up with antibodies. Jolimar raised his, Jolima, did you want to say something? Go ahead. You're muted. I think you try to raise your hand.
Okay,
Go
okay. I
go
have
ahead.
problem with my
No problem. We could
but I hear. Okay,
go ahead.
no problem. I hear.
Oh, you hear? Okay, okay. Did you have a question?
No, no.
Oh, okay, okay, no problem. All right. Concerning the hospitals, will there be hospitals available in every state? Should, in case direct them to have a test there? Yeah, that's a question. Because Sam is asking that question. You know, each area is going to have that. That's why we look. When you take your COVID contact tracing course, one of the things it tells you is that you have to work with the local health department. So yes, it's very important to coordinate with the local health department. Having a meeting with the local health department is important. Now we're talking about outside of Miami. So we're talking about maybe Haiti, maybe Bangladesh. You have to have a relationship with the local health department. You can't be doing this on your own without letting them know, because what's going to happen is you're not going to be able to do a good job, because you're not going to be able to they have a lot of resources that you may not know. So one of the things you should do is, and I'd be happy, by the way, if a local health department in Bangladesh or anywhere in the world wants to know a little bit more about the app, wants to know how we came up with this, what the science is behind it is, I can help with that. So we can have a Zoom meeting and I can explain it to them, no matter where in the world they are. And we could show them. A lot of them, you know, are very cautious of these things because they wonder if it's going to cost any money. Is it going to be? And there's no cost to this whatsoever to anybody, to a government or to a person. So what they need to decide is, do they want to do a PCR test on these people or not? That's up to them. All we do is we just give them the tool. We can't control whether they have the funding for this or not. Edmundo, you have a comment?
Yes. Yes.
Yeah, go ahead.
What happened once anybody has run this app and see the risks? But the reality might change days after or weeks after. When is recommended for the people to go back and retest? I mean, have a risk evaluation again. It is worth to have a recommendation for the people to immediately at the end of the message, maybe, or.
Yeah, you know what? So Camilo, I think what he's suggesting is, and the people that say low risk, at the end you say, please know that if your symptoms change, you can retake this evaluation again at any time.
Exactly.
Using your same sign on, or what is it, username and password. Maliha, yeah, that I do think, you know, honestly, I do think this is one of those. I don't know if you guys know how this happened, but we been talking to people all over the world. When we translated the course to Spanish, we approached other countries, especially Spanish-speaking countries, about, you know, taking the contact tracing course in Spanish, and we thought it was a great tool, which it is. And so we actually have now a relationship with 3 medical schools in Guayaquil, Ecuador, where we're training all their medical students to be contact tracers, and they're going to be contact tracing locally. But when we started talking to them, they said, well, by the way, we have this tool we've been using, and it worked out really well for us. And they went from like 800 deaths a day. I don't know if you remember the footage from March or so. It was in every newspaper and every channel. They went from 800 deaths a day to like no deaths in like a 45-day period. And this is how they did it. And so I said, wow, this tool should be used all over the world. I think the mistake that they made, if you can call it a mistake, is that they linked this immediately to care. So they did 2 things. One is they contacted a company to do this. So the company is charging them like $6,000 a month for the platform. So that, to begin with, is a problem, because many countries don't have the money for $6,000 a month to do this, or municipalities or whatever. And the second thing is that it connects to a doctor. So if you're medium or high risk, it doesn't go to a contact person, it goes to a doctor. And that doctor charges $5 per visit. So when you add the 2 together, it's costing them about $15,000 a month. And this is only for one city in Guayaquil. So right now they already spent about $150,000. They're forecasting a deficit at the end of the year. So I told them what we need to do is come up with a free app So that's where Camilo came on, and he designed this for us. So now it's free. There's no cost to it. So anybody can sign up. There's absolutely zero monthly cost. And you're not connecting to a doctor. You're connecting to a contact tracer who is trained in knowing what to do if you're medium or high risk. I looked at their statistics. About maybe 6% of the people out of 25,000 actually needed medical care. The rest of them didn't. And I'm not so sure that those doctors are really trained in contact tracing. So, but you guys are. So the idea is now you're a volunteer. So this is all free. So now you can go into a village in Haiti and do this at no cost. I think now the challenge is, how do we do it when there's no access to internet, right? Do we do it through USBs? Do we do it through phone apps? But those are different challenges we have to deal with. There are areas in Africa where they don't have internet. So how do we make this available there? And I think, we're going to have to start sending this in a USB drive or different ways. But if they have no access to the cloud, it makes it a little bit harder.
Doug, just to add to that, what you said, we are also starting to speak with Argentina and Bolivia about to do the same thing that in Ecuador. So everyone is welcome to, contact someone that can help, and they can contact Dr. Michel. We are happy to help training Spanish and speakers, Spanish and English speaker CTSs to help the communities in other countries.
Excellent. Sasha is asking, would the PUI fill the COVID risk eval themselves, or would the CTS fill up while asking them what interview? No, they'll be filling this up on their own. And then the CTS would only get the information only if they're medium or high risk. And then at that point, you walk them through the COVID Fighter app, which is basically, that's when you start, we start the symptom reporting. And the beauty of it is all this is free. So the symptom reporting is free, and then the contact tracing is free. So no one would have to pay for any of this. Enrique in Colombia is asking about the Johnson & Johnson vaccine and whether people should volunteer for it. I always say people should volunteer for anything that could help other people. But I've seen some posts on this. And what I've seen is a lot of people think that they volunteer for the vaccine, that they will be immune from COVID, and therefore they don't have to worry about COVID. If that's why they're doing it, they shouldn't do it, because it's very unlikely that any vaccine is going to confer long-term immunity. At least the data doesn't seem to support that. So I would be careful. I think young people should definitely volunteer. I think if you have medical problems and conditions, you should be careful, because all these are clinical trials. We don't know what the side effects are. That's exactly why we are testing it on people. These are basically, you're being tested a product that has not been tested in humans before. So it may have side effects. And that's exactly why they're testing, is to see, to see what side effects are caused. So, I wouldn't only encourage people that understand what the risks are and that read the brochure. This is not something that you do lightly. So definitely, I would be careful. Martin is asking about the reinfection. The only thing we know is that someone in Hong Kong basically was reinfected, and it seems like it was a different RNA sequence of the virus. We have seen reports in the United States of people who have been reinfected. But we have no proof, because basically we don't have a patient that we can say that we did the RNA sequence of the virus today. They were positive, they became negative, and then 3 months passed, and then we have another positive test and an RNA sequence of that virus, and we can see the difference between the two. That's the only way to prove it. So we don't have proof right now in the United States that somebody has been reinfected, but Hong Kong has one patient, and they have actually the RNA sequence of the two viruses that caused it. As you know, this virus can mutate. So what does that mean? It could mean that the vaccine may not confer long-term immunity. That's what it could mean. But we don't know what it means right now. But honestly, I think, we talked about this before, right? And we said, contact tracing is almost as good as a vaccine. And regardless of what the vaccine does, whether it's going to be the best thing or not, I think this is the type of stuff that we can do to, that's almost as good as a vaccine, and it doesn't really hurt anybody. Countries, Yang is talking about countries without community infection. Yeah, I mean, one of the questions it does ask, if you remember the questionnaire, is have you been exposed to somebody who's COVID positive? So whether that person came from abroad or not, it doesn't have the abroad questions. So technically, it's not for countries where it's not, widespread infection. But you never know. You can go from not having community infection to having it any minute. And I mean, the whole theory is that this is a pandemic. So there is community transmission in most places in the world. There may be some places where there isn't, but those are few and far between. It would have to be really isolated areas for that not to be happening. All right. What about a person become positive if they're eligible for a vaccine when it's ready? You mean somebody that's positive? If we don't know the answer. We really don't know the answer to that because we don't know how long immunity. We think from measuring antibodies that it's lasted about 3 months, but we don't know really for sure how long the immunity lasts. Any other questions or comments? Does anybody want to talk about their experience? I want to welcome the group from FIU. We have a group from FIU in the RN to BSN program. They're joining us and they're going to be volunteering to be contact tracers. So hopefully they'll learn about this new app that we're launching today, the Hispanovida or the COVID risk eval, and it'll be useful to you. This is all kind of new to all of us. It's public health, so it's new stuff, and it's exciting because we're developing new alternatives. Anybody have any comments?
I have a question for you. How are you? Good morning, Dr. Mitchell.
How are you?
Good, sir. So the state of Florida also launched a similar type of page, right? So we have the data that you were updating that you do every day through LinkedIn and so many different sources on the number of cases daily and so forth. Where is that data coming from and how is it separate from this? And the reason I ask, it's good that the FIU students are on board. In October, we have something called the Clary Act reporting, right? So demographically, the Clary Act, it's got a history to it, but basically every university has to report certain crimes, certain health statistics, rapes in an area. It's a complete report that accredited institutions must give in, right? And of course, it ties back to financing. So the Clary Act it's an annual report. Are you aware if this information is going to be requested as part of the Clary Act? Obviously, it's important as universities fill back up. UM's got a lot of cases. And then how is this going to affect that daily conscientious report of who's infected demographically, the one that you give, on another thing? Yeah,
so those are presumptive. If you're talking about the app itself, the Hispanovida or the COVID risk eval, that definitely does not go into the numbers because the only thing that goes into the numbers is actual PCR testing, and sometimes they add antibody testing to that, which really they shouldn't, but sometimes they do. But no, this would not go anywhere. Honestly, I think that. Sometimes these reports, and you notice like today, I mean, I do have actually, I could give you the report for Dade County. I could do it real quick. Mm-hmm. This information sometimes is useful, but sometimes, people get a little fatigued with it. Because basically, what I'm worried about sometimes with some of this is that, we may give people the sense of things are a lot better, so there's nothing to worry about. So this is a dashboard from yesterday from Miami-Dade County. And you can see 260 people are in the hospital right now, in the ICUs, 700 in regular hospitals. The positivity rate is 9%. Jackson positivity is 11%. You can see the positivity rate is kind of staying around 9%. You've had some spikes here and there, but it's really consistently above 9%. It needs to be under really 5%. So you see the admitted patients are going down. But you still have 960 people admitted in hospitals, and then Miami-Dade rescue calls. Yeah, it's going down, but you still have 70 people with positive, who are picking up every day. So think about this: every day, Miami-Dade Fire Rescue is going out there and picking up with suspected COVID calls. That's 70 people, 60 people a day in a 24-hour day.
Wow.
These are the deaths per day. As you can see, remember we said it was going to go to 30. We're there. I mean, don't pay attention to this part because this is the part that's important, because they add up the deaths after the fact to when they confirm that they're COVID positive. So we're in the 20s to 30s, that people dying every day. So what concerns me about sometimes this type of reporting is that people then think, okay, well, yeah, it's going down. I don't have to worry. I can go to a restaurant. I can go hang out with my cousin. We're going to have a barbecue this weekend. Should be all right. And then that's when the reinfections go back up again. I'm sure you heard the news that Miami-Dade County is opening restaurants to 50% capacity. And a lot of people are asking questions like, why are the gyms open? Why are you allowing the gyms to open and you're not allowing the restaurants to open? Where's the data that says that restaurants are less safe than gyms? There is no data. All we know is this is transmitted from human to human. But we don't know where is there more risk or less risk. We know that if you don't wear a mask and you're close to other people, you're probably more likely. A buffet you should avoid, right? The breakfast buffet, don't get the complimentary breakfast. If you're traveling, don't get the complimentary breakfast buffet. Not a good idea, because that, when you touch stuff, and that's usually where the virus is. So yeah. So
Dr. Mitchell, I have one more point. So I referred Mayor Jimenez over to you this morning. Mayor Jimenez, our Dade County mayor, he had originally said that he would allow restaurants to open at 50% when we got down to 5%. Okay, we're at 10% now. So the mayor now is running for congressman. So in order to placate voters and so forth. So along the way, politics cannot interfere with science, even though this is not an exact science, but you have a mayor that now is running for a higher seat, which originally said at 5%, we will go to 50%. But now all of a sudden we're at 10%, and now it's okay. So it feels like they're just pulling rabbits out of hats. And at the end of the day, what's going to happen is that we're going to see those increases, right? I read, and I also referred.
There's no question. There's no question. I mean, there's no question there are going to be increases.
I also referred both superintendents to you, and I know you love me referring these guys to you, because they've seen a 7-day decline. So now they're thinking about starting schools earlier, right? So again, a 7-day window, common sense says, that's really, even though they've already said data is kind of skewed, just to go off of 7 days, it's really not enough to be able to say open schools on something with no vaccine. So I'm just wondering, at what point will the medical world start flexing their muscle against the politicians? Because the politicians, they just want to get elected, right? And so the doctor wants to save your life. And so, at some moment in time, the medical world's going to have to come in and flex that medical world muscle and say, excuse me, I know you want to be elected, but you're on record that you would open up when we got to 5%. We're at 10%, and now you're caving into, political needs because you're running for higher office. When do you think that will occur? Because we're not going to be able to control this until there's not somebody that's really kind of steering this. It's a medical problem. It's not a political problem.
That's a good point, Carlos. I mean, I can tell you that, I've always been putting out the truth. And I know that, there's people at the national level, Dr. Fauci and others who are basically always telling the truth about what the risks are. And honestly, that's all we can do. Unfortunately, the way that our system is structured, basically these decisions are not made by doctors; they're made by politicians.
Yeah.
And they have this pressure. We've never had a situation like this before, and so it's evident that people can have this type of pressure and can make decisions that may be the wrong decisions. I don't think it's as much as whether you open restaurants or you open certain things, as whether you have a system that can catch the disease and prevent it from being spread. And I think that's what we're lacking more than anything else. So rather than the artificial figure of whether it's 5% or whether it's a 14-day period, because all of this is artificial. They could just, people could, right now people are not interested in getting tested. So people are not getting tested. So what's going to happen is, you could end up to the point where you're going down to very few people getting tested. The numbers will come down to a small percentage. Why? Because who are we testing now? We're testing people that are at work, right? Where the work is requiring it. And that's the only reason they're getting tested, is because they're being required to do it at work. And they have no symptoms. So the positivity rate is going to start looking like it's lower, but that just means that there's a lot of hidden people that are not getting tested. So I think the solution is something like this app, and that's why we kind of excited about it. If everybody in Miami or everybody in an area took the app today, right, and they got a risk for COVID, I'm talking about people with symptoms, and they got contact traced immediately, we wouldn't have a problem. This would be done. We'd only have to deal with the asymptomatics, right? But the asymptomatics at some point will cause a symptom in somebody. So we'll stop it when it gets there. That's not great, but it's probably better than what we have now. If we could get everybody to use this app and everybody to be contact traced, this thing could be not a problem. But my concern is that we don't have that. And I'm not sure how many people are really getting contact traced right now. I think contact tracing 10 days after the test is probably not going to have any effect, because if you think about it, the people that were going to get exposed got exposed. So, I don't know that works. So that's what we're thinking out of the box about these things, because, there's only one way to do this, and it is to make this accessible. And I think people are tired. People right now don't care about this virus. And all it takes is positive news. Somebody saying, we're going to reopen restaurants. It's gone. That's it. This Friday, come to my house, barbecue. And that's when it starts again. And if we don't have these systems in place to detect it, that's when we're going to go wrong. It's not because we reopen, it's because we don't have the systems in place. Hopefully people will listen and they'll take the test. We've made everything we can to make it free. So it's free. So we removed all the excuses. Like the first excuse is it going to cost me any money? No. How about how much time is it going to take that questionnaire? How much time did you guys measure? A minute or two? And then you get a result of medium or high risk or low risk. You can't beat that. And then somebody calls you for free to contact trace you. If you don't want to do it, it's because you don't want to do it, because there's no cost. It shouldn't take a lot of your time.
What was the original concern, Dr. Mitchell, back in April with fall? If you remember, all medical indicators and everybody was saying this is going to reemerge and kind of just get nastier in the fall. Well, we haven't reached the fall yet. What was the indicator for the fall, and do you think that the fall is still going to be an issue?
Oh yeah, every scientist believes the fall is going to be an issue, because you know what happens in the fall, right? I mean, we tend to have more group gatherings. So we have Thanksgiving, we have Christmas, we have Jewish holidays, we have New Year's. All of these are opportunities for the virus. And then also it gets a little colder. So In Miami, it doesn't get as cold, but still people tend to agglomerate. And that's what causes it. It's not the weather. It's just the fact that in winter months, we tend to be closer together. A hurricane could do it. A major hurricane where people have to shelter in place together, anything that exposes them to other people. Absolutely. So there's definitely going to be a second wave. The question is how high is it going to be? And are we going to be ready for it?
Have you ever seen another illness, Dr. Mitchell, where people could just say, hey, I'm tired of this illness? Like if you have cancer, obviously you have to go through chemo, but nobody says, I'm tired of this and, you know, I don't want to deal with this, right? So this is like one of the few times that I've seen, and as a paramedic, firefighter, that I've seen where people just say, hey, let me walk away, like if they're walking away from a plate of food they don't like. It's very odd. To me that is occurring because it's like it could kill you, obviously, so it's a deadly virus, and then to be nonchalant about it, you know, there's some things that you can't just walk away from, like a bad relationship. You know, this is not a bad relationship, that you can't just walk away from. It's not going to go away. How do you see combating that type of?
You know, it's very hard, Carlos, because I've seen medical professionals say that. You know, say COVID is in the air. We're all going to get it. It's just a matter of time. And you hear medical professionals say that. So it's hard. It's hard because I think we have virus fatigue at this point. I think people are saying, well, you know, 99% of the time, or 90, let's say 80% of the time, you don't end up in the hospital. And 20% of the time you do. And then there's probably 1 to 2% that die. What are the odds that you're going to die? Not very high, but for you, it could be 100%. You could be like my friend, the internist in Orlando's wife, who in her 50s, she was overweight. She caught the virus and she was intubated for a month. And then she needed a lung transplant, which she couldn't get. And she died. And like all the other people that die. So, yeah, I mean, this could mean life or death to a lot of people, and that's what we don't understand. We're not understanding either. And you know, it's also the responsibility, because you could say, well, I'm 20, or I'm 18, or I'm 25. I'm not 65, so I should not worry about this. But you don't realize that at some point you will be probably somebody you love in contact with that person, and that's the person that's going to die. And are you prepared to face that consequence? A lot of people don't seem to believe that they can give it to someone else. And so those are the types of considerations that we should have. Sasha, yeah, sorry, go ahead, Carlos.
No, thank you, Dr. Mitchell.
Oh, you're welcome. You're welcome.
Okay.
Sasha, I don't know about advertisement for the COVID fighter. I mean, for the COVID risk eval. I mean, we're thinking like social media. Were you thinking of something more specific? Sasha?
I just want to make a comment.
Oh, go ahead, Juan. Yeah.
Okay. My comment is that with respect to planning, usually in public health, you do plan every 15 days based on your statistics. So the prior speaker was mentioning the 7-day period. It's actually, from public health point of view, the classic public health point of view, it's every 15 days, based on the statistics, you do a plan. And then within the next 15 days, you're going to review the previous plan to see if that plan worked. If that plan worked for 15 days and the statistics move into lowering, then you keep the plan. If they didn't, you revise it and you make a decision whether you should make a stronger measures, or if you hold on to the measures because you or the society cannot accept any stronger measures.
Juan, so this is Carlos Villanueva. I'm the one that asked that question.
Sure.
The 7-day number, The 7-day number that I'm using, I'm quoting both the Dade and Broward school superintendents. They're going off of the last 7-day data where they're seeing a decrease, and now they're saying they may move the school opening dates to earlier. So now you're saying that there's a requisite somewhere that it's a 15-day research, correct?
Well, what I'm saying is what is usual and customary within public health officials, like World Health Organization, classically CDC, without political pressure, is the way you act scientifically is with 15-day window periods. And you plan as a public health official based on 15 days data, and you make decisions based on that. You don't plan every 7 days, only it is an emergency and you things jump all over the roof. But with respect to the pandemics, if you follow up those institutions, you're gonna see that there's always there's usually a 15-day period to do the planning.
Juan, thank you so much. Dr. Mitchell, is there any way that we can assure that we invite the school boards onto this weekly call? Because obviously they're lost. I mean, you know, if the superintendents are misinforming the public on a 7-day, and then Juan here saying, you know, the criteria here is 15, then really the superintendents should wait to gather that 15-day and then speak, because you're confusing a lot of parents, and you know there's a lot of stress that goes with that. So I'm wondering, are we in this call engaging some of these community leaders? Obviously, it's an open invitation, but how do we assure that we get, you know, somebody from the chief of staff in the mayor's office, somebody from the school board, because this is a very informative community call, and obviously Juan just corrected that the superintendent really should be waiting 15 days to be able to speak out on what their move is based on 15 days worth of data. You know, it just really seems amateuristic from the school board's point of view. And I'm wondering how we could help them help themselves. Does that make sense? I mean, how could we enforce that?
It's hard to enforce participation. You know, it's kind of voluntary. I think that the most effective we could be is by increasing the size of and interest in our group. And that's why we're doing these weekly, because we think that the more people know, because at the end of the day, you know, politicians, and that includes the school board. I mean, it's all the politicians. If they respond to community input. So I think if more people kind of watch this and understood what the considerations are, then they would have a voice that would get to somebody. Because right now, what the politicians are hearing is, you know, they're hearing from restaurant owners, look, I'm going to go out of business. And they're seeing it. People are going out of business. And so they're saying, okay, well, what do I need to do? And I think what's missing here is this piece of what can we all come up with together so that we can have a plan that to deal with the surge, because there's going to be a surge. Let me just give you the news. When restaurants open again next week, we start having kids go to school, there's going to be a surge. There's no question. The question is how we're going to deal with it. It's not that, is it going to be a surge? Are we going to wait the 2 weeks that it takes to see it went up and how many people died? No, that's not what we need to do. What we need to do is, what are we doing to make sure that we catch this early? Set 10 days results for labs are not acceptable. And I'm telling you, we do testing ourselves, and we've had issues with some. You know, we have labs that we send the work that we work with. We've had to move some of that around because basically we're waiting 10 days for a result, and then we have our contract tracers call somebody who was saying, yeah, well, why are you calling me now? You know, it's 10 days later. I already did what I did. I don't even remember what I did back whenever I was infectious. And so that's how we came up with this solution. But I do think that we need a solution, whether it's this app or another app that does the same thing. They can call it something else. We'd be happy to share the algorithm. It's not that complicated. I mean, we need to have something for sure. I think I see something. I mean, I think there's a questions about, someone's asking about how these things are implemented in the United States. Like Alexander's asking if in our country, no, there is no mask. There is no mask enforcement nationally. It's local, unfortunately, and I think that's one of the issues. I think everybody kind of agrees that if everybody wore a mask all the time, that the graphs would go significantly down if we could enforce that. But how do you control? This is the problem: is if I'm having a barbecue in my house and I'm inviting all of my family, my uncles, my aunts, my cousins, and 10 people show up who don't live with me, right? How do you enforce me wearing a mask? How do you enforce them wearing a mask in my house? That's the problem. And that's what you can't enforce, because how do you go into somebody's house? I mean, is the police going to drive by somebody's house and say, hey, there are too many cars, they're having a party, it's Sunday. Let me go check out the barbecue and see if they're wearing a mask or not. They have no ability to do that. They can only stop you if you're at a Walgreens or a Walmart or a Publix, and if you're not wearing a mask. And honestly, those are probably the situations where you're less likely to expose people because you're far away from people. So you're more likely to contaminate someone who comes to visit you in your house than you are to contaminate someone at the mall. But we enforce the mall, we don't enforce the house. But I think the most dangerous thing that we're doing, I think, is making people feel that this virus is gone and that it's just going to get better from now on. I think that's the worst thing we can do of all the things. Let's see. I think, does anybody have any last minute thoughts or questions? I think we're kind of beyond the hour. I don't want to take up more of your time, but next week, as you know, we do this every Wednesday, and we're open to ideas and making things better. I hope you. I'm going to put the sign up for the app on the Facebook so that you can copy and paste it from there. It's hispanovida.com or covidriskeval.com. Please practice it, use it, and so you can see how it works. And I hope if you have any other suggestions on how we can make it better, please let us know. Thanks, everybody. I hope you have a great day.
Thank you, Dr. Mitchell. Always great.
Thank you. Take care.
Thank you, everyone. Stay safe.
Thank you very much.
Thank you. Good luck.